the chances of infection are very high in young children, and we never used to talk about children beyond 5-6 years of age and adolescents and adults. And if you look at this data and look at the risk ratios, right? So the risk ratios, and this is classified between LTBI positive and baseline, and regardless of the LTBI status. Now, if you look at any of these data, so supposingly you look at data regardless of the baseline LTBI, and in the first 12 months, then the risk ratios are like 25 or 26 in 0 to 5 years. They're like 25 in 5 to 14 years, and again 25 here. And if you look at in 24 months time, they're 15, 6.3 and 11.7, just highlighting the fact that all household contacts are at a very high risk of getting disease, and hence the WHO came up with a guideline that in countries with a high incidence of tuberculosis, even in children more than 5 years of age, adolescents and adults who are having a household contact with pulmonary TB, which is confirmed, they should be offered prophylaxis. And hence this algorithm was changed. So if you have a household contact irrespective of age, if you have children over 1 year of age who have HIV, you ask for symptoms of tuberculosis. If they're obviously symptomatic, you investigate them for a disease. If they're not symptomatic, less than 5 years, even if you do no investigations, you should start them on a TB preventive treatment. Now, 5 to 18 years in adults, what the program still says is that you ideally test them and treat them. So which means that if the person actually harbors the infection, it makes more sense to treat them. But again, because the tests are difficult to do and the sensitivity and the specificity is not completely good, it is absolutely fair enough that you put them on ionized prophylaxis if you cannot test them. Now, what do we have with us? Well, most of us have isoniazid, where we use it for around 6 months. The efficacy is something like 65-70%, and a very minimal toxicity. Now, what is coming up is a rifampicin isoniazid, also called as a 3-HP regime. It is a weekly regime. Again, the efficacy is similar. The toxicity is low. The main benefit which has been cited, you can use it every week, which means 12 Sundays you take it and you're done. And then there's a conditional regime where we use 1 HP or daily treatment with rifampicin and isoniazid, which can be considered. But rifampicin is not available commercially as of now. I heard, but I'm not sure regarding the trials which are going on by the government of India in some states where they were using the 3-HP regime. And I think Dr. Kabra sir might be having a better knowledge on this, and we can ask him in the question answer round. So these are the doses for 3-HP. I think we can skip them. There is involvement of the private sector as well. We need to link it with the national TB program. We need to notify actually even the contacts, and it is quite helpful because the program is not just giving the medicines, but trying to give prophylaxis in many other things. If you talk about an MDR patient, well, previously we used to understand that if you have a person in their house who has an MDR TB, then usually we used to say that you do not give any prophylaxis and isolation was the only way. But recent data suggests that you can use prophylaxis with some drugs, and we are going to talk about it. And there is a definite reduction in the risk of developing disease. So this is what we have. So if you have someone in the house